by percutaneous endoscopic gastrostomy in children. Percutaneous endoscopic gastrostomy was introduced in 1980 and is a very effective method for enteral feeding by children especially. When we have a gastrointestinal tract is functioning, difficulties in oral intake for more than 6 weeks to prevent sarcopenia and to correct nutrient deficiency. And to improve life quality of our patients. Benefits of this method, we can see improved nutritional status, lower complication risk, lower gastroesophageal reflux frequency, and lower percent of aspiration, and less discomfort for the patients. This is our set for procedure. We can see indications for this procedure. We use this method for long-term feeding of patient instead of nasogastric tube by motility disorders, esophageal obstruction, disorders of swallowing, facial fractures, and neurological damage, coma, and cerebral palsy. Contraindications of this method: terminally ill patients, with a patient with a high post-procedure risk, with contraindications for fibrogastroscopy, inflammatory disease of the anterior abdominal wall, serious ascites, hepatomegaly, portal hypertension, and peritoneal dialysis. Alternative of this method, these are orogastric tube, nasogastric, and oronasoileal tubes. Surgical alternatives, it's open gastrostomy and laparoscopic gastrostomy. This is insertion techniques. We used gastroscopy. We found a specific place for the insertion of the needle, like we see here. Put the cord into the stomach, and after that, we put the tube through the esophagus. And this is the this is one of our patients. This from the right side is the endoscopy. We see the place of the front abdominal wall and put the needle. This is the cord, and after that we pull out the nasogastric the tube. This is the post-operative period by our patients. We use the gastroscopy after the procedure to see the tube. These are the food by these patients. Complications, they are rare, but in early post-operative period we can have a bleeding of perforation, aspiration, ileus, pneumoperitoneum, wound infection, liver damage, and spleen damage, and colon perforation. In the later post-operative period, we can have obstruction of the stomach, peritonitis, leakage of stomach, ulceration of the stomach, obstruction of the catheter, hypergranuloma, and gastrocutaneous fistula after when we remove the catheter. In our clinic from 2019 to 33 year, we have 49 patients with this procedure, 18 girls and 12 boys. We use Olympus and the size of catheter is dependent of the age of our patients. This placement was feasible in our cases. We use this method even in case with severe deformities, and by 4 of our patients we use this modification, like we said, mini laparotomy, because the stomach was very high and it was very difficult to use this method without laparotomy. Complications by our patient: leakage is by 4 patients, pneumoperitoneum by 2 of them. We treat them one of them was treated conservatively and one operatively. Wound infection by 3 of our patients. Late complications are hypergranulation of the stoma, adhesion to the skin, and lethal exit was in 8 cases, but this lethal exit was not connected with this procedure. This is hypergranulations and pneumoperitoneum by one of our patients. We are a multidisciplinary team because we need from a gastroenterologist for gastrostomy and a structured program in the ambulatory or hospital conditions, and varying of duration of the window period. In conclusion, we can say this is very good alternative to open surgery, and visual conformation is very good for the optimal position and function of the catheter, and low complication rate by these patients, because in a big percent of cases they are very severe ill. Thank you for the attention.